All right. So thank you, everyone. Thanks for joining. This is our second little session that we have here. We're going to be going over shock, trauma, and some MSK injuries tonight. Thank you for joining. It means a lot to me that you all are here, knowing that you're taking time out of your busy lives to learn a little bit more and improve some of your skills and knowledge as patrollers. So that's, I think, a really great thing, and I just want to celebrate that with you all. The audience tonight will probably have some people continue to trickle in. So everyone just stay on mute, if you will, and then you can post in the chat. I'll be looking at the chat as I kind of go through the lecture. And then if anything comes up that's noteworthy, we can talk about it, and then otherwise we'll turn off the recording at the end, and any other questions that you might have we can dive into. So one of the things that we talked about last time, and I think this is a really good way to kind of just frame a lot of the work that we do, because I don't know if we give ourselves enough credit for some of the circumstances that we find ourselves in when we're taking care of our patients. The Department of Homeland Security has this definition for austere EMS. So austere medicine, wilderness medicine, and it's when you have a specific set of criteria. So you have ongoing physical environmental threats, wind, cold, altitude, check. Limited medical supplies, technologies, resources, check. Limited expertise, check. Limited communications, check. So really, as ski patrollers, we're taking care of patients in austere environments, and that comes with a lot of challenges. We don't have trauma surgeons with us unless you're fortunate enough to have one on your patrol. You know, we don't have a whole ER. We're not able to give medications. We don't have surgeons that we can page, and so we're really limited on a lot of the work that we can do, and we have to. There's a lot of appreciation that we need to have for the environment that we practice in. So just so that you all kind of have some reference for the OEC text of some of the things that we're going to be going over, the 4 big chapters that we're kind of diving into some of the material on are chapter 10, talking about shock, chapter 20, getting into some of our MSK injuries, chapter 23, looking at some chest trauma, and then chapter 24, looking at pelvic trauma. So we talked about this last time in our first video, and if you missed it, we have it on YouTube. It's in the link that you got from the Far West Division email. Take a look and watch it, because it really helps frame some of the work that we're doing here. But our kind of goal, very quickly, within 60 seconds of getting on scene and looking at a patient and what are we dealing with, we obviously need to obtain informed consent before we start evaluating and treating our patient. But we're trying to kind of figure out, are they big sick or are they little sick? Are they big hurt or are they little hurt? And that's going to really help us frame some of our, you know, how fast are we going to expedite our care? Are we going to stay and play, or are we going to load and go? Those are the things that we need to be thinking about as patrollers when we get on scene. And we really want to make sure that we have a solid primary patient assessment, that we're getting through those life-threatening emergencies, and then that we also have good history-taking skills and a really good secondary assessment, so that we can find those other issues that we need to address. So we're going to start off with a little question here. You can post your answer in the chat with what you think is the correct answer. So we're treating a trauma patient, and during our initial assessment, he was anxious, but he had a good radial pulse. Upon reassessment, which of the following findings would confirm that this is a patient that is starting to transition to decompensated shock? Is it when A, they're complaining of extreme nausea, B, that their heart rate is increased from 80 to 140, C, that their blood pressure is 90, or D, that their respiratory rate has increased to 30 breaths per minute? So what do you guys? Yeah, so a lot of these are symptoms of when we have a patient that's in shock, there's going to be one in particular that we're looking at that is starting to some clues that this is a patient that's transitioning to decompensated shock. So it's actually C. It's when that patient's blood pressure is now 90 millimeters of mercury. And so let's dive in. Now, I know a lot of you will be asking me, so without a blood pressure cuff, how are we going to know what their blood pressure is? One, I think you should carry a blood pressure cuff because it's a really useful tool. And we'll talk about some of the ways that you can use it tonight. But two, the radial pulse is kind of giving you a decent indicator of what that patient's blood pressure is like. And so if you're not feeling a radial pulse, but you can feel a carotid pulse, or as Derek mentioned, a brachial pulse, then you know that that patient's blood pressure is probably less than 90. And so that's where you really start to worry that this is a patient that's in decompensated shock. And I have a great slide coming up that will kind of frame it and really show you what that process looks like. So kind of getting back to the basics. So the only way that our body can transport more oxygen, so when you have inadequate perfusion, your tissues aren't getting the oxygen that they need, there's really only one way that your body can do it, which is to speed up the circulation of your blood. And so it's going to make your heartbeat go faster. But if at the same time you have a decrease in the amount of blood that you can circulate, you're also losing that oxygen delivery capacity. And so at some point you are going to have where your blood is not able to circulate fast enough with enough oxygen to get the tissue all the demand that it has. And once that happens, that is the situation that is called shock. So our bodies have really no oxygen reserves at all. We can store fat for about 30 days. You have about glucose stores for a day, but the amount of oxygen reserve that you have in the system is about 5 minutes. So once you've exceeded that 5 minutes, you don't have oxygen reserve anymore. So shock, you can also really think of as being death in progress. So there's three kind of big causes of shock. You can have a pump problem, which is that the heart is not able to pump that blood correctly. So that can be when your heart is failing. You can have a pipe problem, which is where the veins and arteries are expanded too much, or your blood is starting to pool in the tissues. And you can have a volume problem where there's not enough blood to pump through the system. And so that can be things like internal and external bleeding, but it can also be dehydration. You can get shock with patients that have really severe diarrhea, vomiting, and you can also get it with patients that have really bad burns. So those can all be volume problems that are leading to shock. And so this graph here on the right-hand side, that bottom axis is as time goes on. And so what you can see in compensated shock, which is the left half between that dotted line, is that the body's kind of doing everything that it knows how to do. So your heart rate is going up because you have more oxygen demand. Your tissues need more oxygen. So your heart is doing what it can do to increase that circulation. Last time we talked about that if you have a, pale skin and anxious is something that should be a red flag view during your patient assessment. There's a good little saying, which is that if your patient is sweating, you should be too. And a good clinical pearl is that anytime that you have a patient that's tachycardic, that's something you really need to investigate. So that's why I have that little magnifying glass next to increasing heart rate. You got to be thinking about shock when you have a patient that is tachycardic, because you want to catch shock while it's still in that compensated shock phase. There's things you can do to try to help prevent that patient from going into decompensated shock. And so really what makes it challenging is that their blood pressure will be totally normal during this phase. That first phase of shock, blood pressure is totally normal. Then we have where that body can no longer compensate. And that's when you get that crash of the blood pressure. So usually it's going to be less than 90. And we're talking about systolic blood pressure. So the blood pressure on top, you'll typically feel a loss of a radial pulse at that point. And the other thing that happens is with decompensated shock, you're going to typically get a patient that's in altered mental status. So altered mental status is really challenging in a wilderness environment because it's a big distracting sign of shock. When you get on scene and you have someone altered, you're thinking, was this person at the bar for the first half of the day? Have they taken drugs? Do they have something else going on? Did they hit their head and they have a concussion? Our brain, our kind of bias doesn't lead us to shock when we see a patient that's altered. But the brain is really sensitive to a lack of oxygen. And so that's why you get that altered mental status. Now, another thing, and it's not a perfect scenario, but it helps illustrate some of the effects. The brain is also really sensitive to a buildup of CO2. So when you have low brain oxygen, you have a patient that's hypoxic, they tend to be agitated. Agitated is the usual response that the brain will have with low oxygen. So you're going to treat that with giving them oxygen. Lethargy, on the other hand, so when you have a patient that is lethargic, unresponsive, sluggish, that tends to suggest that they actually have a buildup of CO2. And so that's a patient that will improve with ventilation by a BVM. So if you ventilate that patient, you're going to help blow off that CO2. That's going to improve their altered mental status. The other thing that we have to think about when we have a patient that's presenting with this kind of clinical picture, we also want to be thinking about hypoglycemia, because that's another big distracting cause of shock-like symptoms. So with a patient that's hypoglycemic, we will often find that they're altered, they're tachycardic, and they're sweaty, they're diaphoretic. So you can see where there's some overlay there. One of the things that we talked about in the last session is, one of my, when I'm getting vitals, one of my red flags that goes up is when I get a heart rate that's higher than their systolic blood pressure. That tells me something's going on. I need to be a little bit worried here. And this graph kind of illustrates that you see where that blue line of heart rate goes above that red line of blood pressure is when you have that patient that's in decompensated shock. So one of my favorite things to do with a blood pressure cuff is that I don't get out my stethoscope and listen to a systolic, diastolic, and get the whole trend, but I will put a blood pressure cuff on. I'll be checking their pulse. I'll get my pulse done. I'll inflate up that blood pressure cuff to where I lose the pulse, and then I'll slowly start letting the air out. And that number that you get when you start to feel their pulse again, that's their systolic blood pressure. So you can do it with no stethoscope. You can get that top number. It's a really valuable piece of information. So the types of shock, we have hypovolemic shock. That's a volume problem. And you may not get a decrease in their blood pressure until they've lost anywhere from 20 to 30% of their total blood volume. So our bodies are really incredible at being able to compensate when we have blood loss and keep our blood pressure normal. Cardiogenic shock, that's a pump problem. We'll talk about that when we do a cardio lecture later in this series. Distributive shock, that's a pipe problem. So we'll see that with anaphylactic, septic, or neurogenic shock. Talk about those later. And then the last is obstructive shock. So this is kind of a combo. It's where you have both a pump and a pipe problem. And that can be things like a tension pneumothorax, where you have pericardial tamponade, and even pulmonary embolism. So we'll dive a little bit more into hypovolemic and obstructive shock causes here in a little bit. The other thing that we talked about last time, this is a concept that comes out of military medicine. a lot of research that has gone into this. And so the big takeaway, I think, for us as patrollers, and it's a little bit counterintuitive, cold blood does not clot. That is the takeaway from this slide, is that if you have a patient that is hypothermic, they will not clot. They are going to bleed easier. And if you had bleeding under control and now they're hypothermic, they may start bleeding again. So what happens is with acute blood loss, and so on the military side, we see this with hemorrhage and with combat-related bleeding, right? So when you have acute blood loss, you're going to start to develop hypothermia right away because you've lost warm blood. Our blood is keeping us warm. So if you lose a lot of your blood volume, you've lost part of your warmth. And then as a result of being hypothermic, your blood clotting becomes impaired. So now you don't form blood clots. You bleed easier. So now you lose even more blood. Then you have a decrease in that oxygen-rich blood. And so the body starts to build up that lactic acid. And when your blood becomes more acidic, it also has an effect on your heart, that it decreases your heart performance. So now the heart can't as effectively pump, you're hypothermic, you're losing more blood. And so the way that this is kind of called the Triad of Death. The way that you intervene here is you stop the hemorrhaging when you can, and you prevent them from getting hypothermic. And if you do those two things, you've at least attacked two parts of that lethal triad, and you can really improve your trauma patient's outcome by really being mindful of the fact that cold blood does not clot. So with the management of shock, we kind of have three tools in our tool chest that we can use to deal with this problem on the Hill. So one is we got to control bleeding where we can, when we can. We want to, when we have patients that are in shock, we want to be administering oxygen because we're going to increase that oxygen capacity. We're going to hopefully get more oxygen to those tissues. We're going to prevent that buildup of lactic acid, and we're going to be able to prevent some of those sequelae from having low oxygen. And then we want to prevent heat loss. So we want to make sure that they're warm and that they stay warm. And then remember that this history of our patient is really important, because if they're a diabetic, we might also be thinking, do we want to administer some glucose to this patient, if that could be part of what's interacting with our vitals. And so we're assessing, we're intervening, we're reassessing. We really want to be on top of it when we have a patient that's in shock. So we talked about last time the OEC, primary patient assessment. You have, if you have severe bleeding, you start with C, then go to airway breathing disability. If you don't have bleeding, you do ABCD. And I gave two examples of some other approaches that other disciplines in the wilderness environment have. On the left is kind of the typical that we talk about with some of our EMT and paramedic instruction. And on the right is from our combat medicine. And so the March algorithm is really interesting, because you will see that in their primary patient assessment, the last thing they're looking at is hypothermia. They want to make sure that they don't get hypothermic patients. And I think it's there's a good lesson here for all of us, that we really want to be thinking about how hypothermic might our patient be? How long have they been sitting in the snow? Did they decide to ski in jeans today? Did it take us 15 minutes to get there? Are they wet? Are they cold? Is it windy? We want to be thinking about these things so that we can make sure that our trauma patients don't get hypothermic. History taking is really important in a trauma patient, because you may be the last person that gets any of this information before that patient becomes unconscious or altered. And the information that you glean here is going to be really valuable to the team at the hospital. So when we have a patient that might be losing consciousness or their condition is worsening, we really want to prioritize getting that sample done I think it was Derek last time that said otherwise you're going to be doing veterinary medicine. And we also want to think about our other resources there. Are there family members or a friend? If that patient's unconscious, can we get some sense of what history they might have? Are they taking any medications? And so when I do medical history, I like to ask my patients with a specific list. So I'll say, have you ever been told you have high blood pressure, high cholesterol, heart problems, diabetes? Because I will find that patients often think that because they take blood pressure medicine now, they don't have high blood pressure any longer. It's not one of their medical conditions. And then it's also important with a trauma patient, when we think about last oral intake, I will say, when did you last have anything to eat or drink? Because if that patient is going to be going to the hospital and needing surgery, when they drank last is also going to be a really important consideration for that team. So OEC6 mentions two medications in the kind of in these chapters, and I wanted to frame a little bit more for how this interacts with our trauma patients, because they were fairly brief, but I think these are two really important medications that you should be aware of. So the first is beta blockers. So this is a type of heart medicine. The naming convention for beta blockers is that they all end in lol. So metoprolol, atenolol, propranolol, they all end in lol. And there's more than 26 million Americans that are prescribed this medication. It's the number 6 most commonly prescribed drugs. And it is used to treat a whole host of different cardiovascular diseases. So they use it in heart failure, but also in tachycardia and arrhythmias. It's used for blood pressure. They will give it to people after they have had heart attacks. And why does this drug matter so much when we're talking about shock? Is that a beta blocker is literally an adrenaline blocker. So epinephrine, that drug that we get when we get fight or flight, when we are anxious and our heart rate is going up, the epinephrine normally binds to this receptor and increases your cardiac activity. That's the bear is chasing you. You better be able to run. Your heart kicks into full speed. Beta blockers, the medication binds to those receptors. And so epinephrine does not have that effect. So when you have a patient that is on a beta blocker and they are in shock, they very often will not be tachycardic because their heart can't get tachycardic. That receptor is blocked by the drug. And so really important to get that good history, especially in a trauma patient that might have a heart condition, because one of the things that we're looking on early on is, are they getting tachycardic? Are they getting tachycardic? We may not get that clue with that patient if they're on a beta blocker. The other big one is blood thinners. So there's more than 8 million Americans that take anticoagulants, and there's 26 million Americans that take daily aspirin. So if you have a patient that's older, 1 in 3 older Americans are on aspirin. We do this because stroke and heart attack are a leading cause of death. And by thinning the blood, we can decrease that cause of death. So it's a really important medication. But when you have a patient that has trauma, they may bleed easier and the bleeding may be harder to stop because of their blood thinners. And so there's two kind of different ways that these medications work. One of them is that it prevents and slows blood from clotting. And those are anticoagulants. So that's going to be, Coumadin, and then some of our newer ones are like Eliquis and Xarelto. And then there's antiplatelets. So part of the way that clots form is that platelets will kind of clump together. And once those platelets have clumped together, it gives a surface for that clot to fix to. So antiplatelets will make those platelets not sticky. They won't clump together to get that clotting cascade going. And so where the big takeaway for us is that any patient that's on a blood thinner or aspirin is at an increased risk of having brain bleeding after a head injury. So if you have a head trauma patient and that patient is on blood thinners, that is really someone that you want to expedite transport for. One of the ways that you can feel if a patient has atrial fibrillation, so it's one of the heart arrhythmias that you can actually feel by taking a pulse. And the way that it is classically described is that it's an irregular rhythm. So when you're feeling their pulse, there is no connection between beat 1, 2, 3, 4, 5. It's in a totally irregular pattern. The intervals are different. It's random. You can't predict it. And so that may give you a clue that you have a patient that has atrial fibrillation. So controlling hemorrhage. So when we talk about shock, we got to be able to control hemorrhage. And there's kind of three things that OEC talks about. So we have direct pressure. So you can consider, if you want to get something like a pressure wrap, there's a number of these now that are commercially available. Huge improvements that we've had in this technology because of our wars in Iraq and Afghanistan. So it's a hemostatic gauze attached to an ACE wrap that you can really get tight over a wound to get some direct pressure. Major bleeding can kill a patient in 3 minutes. So one of the things that we do is when you're doing your head to toe, or even in your primary, if this is a patient that has obvious bleeding, you do what's called a blood sweep. So as you're palpating, you're checking your gloves. Am I having bleeding? If you have a patient that has trauma, you're wanting to expose that area and make sure that, we know that they may have an arm fracture. What have we looked at? Is there bleeding there? Is there a laceration? Is there bleeding that we need to get controlled? And so, again, that massive bleeding, they're losing warm blood. We got to be also thinking about if they're getting hypothermic. One of the things that you can do with direct pressure as well, if you need your hands because you got to get your bandages, or you need to open up some supplies, you can use an elbow to apply direct pressure, especially to an extremity. You can use your knee to apply direct pressure. So don't be afraid to use some of the other tools that you have that are less obvious to get direct pressure on a wound if you need to be getting something else with your hands. So wound packing is the method that we would do if it's somewhere on their trunk or torso, in their abdomen, high in the extremity where we can't get a tourniquet above it. And so one of the things with wound packing is that you're not just kind of, loosely putting in some gauze. You are packing that in with, a really tight pressure. You want to fill that whole space. And once you get that whole space packed, you need to be holding direct pressure on the wound for at least 3 minutes. Even if you have hemostatic gauze, you really have to be putting pressure on for a long period of time, especially when you have a wound that you're trying to pack. The top picture there, so one of the pressure dressings that OEC talks about is using a cravat, putting that over after you've done your packing, and tie that off with a square knot. So tourniquets, this is the other way that we're gonna prevent bleeding, especially if we have something that's in an extremity. And so that bottom center picture is the combat tourniquet. These are great tools. I would really encourage you to carry one. I saw something in the news the other day that there was an arrest made on a individual that was planning to carry out a mass shooting at a ski resort. Unfortunately, I think part of the world that we live in, we also have to be thinking about what might we do with a mass casualty situation where we have people with significant bleeding. These combat tourniquets are a great way to do it. You can also use a cravat that you carry in your pack. Lots of ways that you can improvise tourniquets. One thing that is worth noting is that tourniquets are painful when they are applied. So you definitely want to warn your patient that it is going to hurt when you tighten that tourniquet. With the combat tourniquet, there's a strap. So you tighten the strap as tight as you can get it. Then you're twisting that windlass. Then you secure it, it clicks into that little plastic housing, and then you want to mark the time. If you're doing an improvised tourniquet, it needs to be at least 2 inches wide. If you want to apply it to the bare skin if possible, at least 2 inches above the wound. And then if you're using like a cravat, one of the things that's helpful is wrap it around once before you do your first square knot, so that when you're twisting, that fabric isn't twisting into the skin as much. And then when you've tightened it and the bleeding is stopped, you want to check for a distal pulse after. If you still have a pulse, tighten the tourniquet more. Your tourniquet's not tight enough. If you're going to go through all the work of putting on a tourniquet, put it on right. You should not have a distal pulse below. If you still have bleeding after you've done your tourniquet, as tight as you can get it, you can apply a second tourniquet higher up on the extremity. What the research has shown is that a tourniquet that's left on for less than 2 hours has minimal risk of complications. Even if it is in a patient that had only venous bleeding and didn't need a tourniquet, you still have minimal risk of complications for less than 2 hours. So there are a lot of different ways that you can improvise a tourniquet. Again, 2 inches thick on the material, 2 inches above the wound. The windlass can be any sturdy object. So you can use your trauma shears. You could use a ski pole. You could use a stick. You could use a metal pen. If you have tongue depressors in your patrol room, you can tape a couple tongue depressors together. You can use a carabiner. So a lot of us have maybe one combat tourniquet on us, but a few cravats and a few other things. So if you need to get creative, this is a couple ways that you can do it to improvise a tourniquet. You want to secure the windlass after you've tightened it. So that the picture with the tongue depressors kind of illustrates this well. You need to do a second piece of fabric that is preventing that windlass from spinning back on itself after you've gotten it tight. You can put a carabiner in under your fabric before you tighten it, and then hook your windlass through a carabiner. You can use tape. You can use the tail of the fabric from that you did your original square knot with. If you have enough of it, you can wrap it around again and then tie the windlass that way. And then even a blood pressure cuff, while you have a patient that has significant bleeding and you need to get your tourniquet out and you're getting things ready, throw a blood pressure cuff on and crank that thing up. That's going to give you some pressure. That's going to get you a little bit of time to get your tourniquet in place and get your bleeding under control. Blood pressure cuffs aren't designed to stay inflated at a high pressure for a long period of time. They tend to leak a little bit of air and you'll have some issues there. So you don't want to use that as a long-term solution, but a blood pressure cuff is a great way to get some control while you get some time to get your tourniquet good to go. And then the other thing that is improvised junctional tourniquets. And so when you have a patient that has bleeding high up in the groin or even in the armpit where you're not going to be able to get a traditional tourniquet, what OEC talks about is that you are going to pack that wound. That is the type of wound that you would do wound packing on. So with there's a number of different agencies that have looked at this, and there's actually even commercially available devices. So if you have, splints or your Hill actually has any of these junctional tourniquets, they're great tools. You can use a water bottle that you put at that groined area right over the femoral artery, and then put on a pelvic binder, tighten it down, and that is going to compress the femoral artery and stop that bleeding high up in the leg. You can use a helmet. You can do anything rigid. So you could do a rolled SAM splint. You could do a ski boot and secure it with a pelvic binder, tighten it down, and that's actually going to get you bleeding control high up on that femoral artery so that you can hopefully prevent that patient from bleeding out. These are finicky. They're likely to be dislodged with patient movement. But this is one of those emergency situations that you have a patient bleeding out on your hill, and you've packed the wound and they're still bleeding. Don't be afraid to improvise and try to get some pressure on that wound. You can also make a pelvic binder with 2 combat tourniquets. So if you attach 2 combat tourniquets together, that'll give you a wider width. That's one way that you can get some pressure there. And then I'll show you a couple other examples here. So junctional tourniquets continued. You can also, so this is a hiking boot at the bottom. If you have a stiff enough boot, it'll work. And so they've done these studies where they've used all these different devices and then used the Doppler to measure if there's any blood flow past it. And all of these different things are effective at actually compressing the femoral artery there and actually preventing that patient from continuing to bleed. So, this is going to be the situation that none of us ever want to be in, that you have a patient that's bleeding out and you can't get control of that bleeding. This might be one of the things that you try to get that bleeding to stop. So pelvis trauma, moving on a little bit. So trauma is the leading cause of death in patients between ages of 15 to 24. Pelvic injuries are a really high energy injury mechanism. So when you're thinking during your scene size up about mechanism of injury, this would be one where this is going to be a really significant mechanism. And you want to make sure that you're doing that thorough trauma evaluation, that head to toe. Mortality from pelvic hemorrhage is upwards of 30%. So 30% of these patients will die. Over 50% of patients with pelvic fracture will develop shock. So if you have a patient that has a pelvic fracture, they are likely going to be also in shock. And 85% venous bleeding. So again, it's not, it's not that arterial bleeding that we're thinking about, but there is a lot of blood supply in this area for all the organs and all of the surrounding structures. And so this is a really significant mechanism of injury here. There's kind of 3 varieties of pelvic fracture, and we have some opportunities that we could run into any of these 3 with our work as patrollers. So the kind of classic, when they talk about that open book fracture, that is going to be someone that has front to back impact. So they're crashing into something with the front of their pelvis. So that could be a skier versus a tree. And that's that top row of pictures there. You can have lateral compression, and that can result in different types of pelvic fractures. So that might be a skier collision where you have one skier that's going sideways into another skier. And then the last is you can have vertical shear injuries where you have a fall from a chairlift or maybe even in your terrain park, and that can cause pelvic fracture. So these are very painful, often associated with life-threatening hemorrhage. And so our goal is to minimize movement, which will then reduce bleeding, provide some comfort. There's a number of commercial devices that are available for this, but they're not always the most practical to carry, and sometimes they're expensive. So, you can do the sheet. There's a lot of different methods, and I'll show you a couple of those. To illustrate, one of the things that we also talk about when we're stabilizing a pelvic fracture is that we want to tie the feet together, right? We want to internally rotate the hips. So I can actually illustrate this, or you can illustrate this on yourself. So if you feel for your iliac crest, your hip crest, put your legs out in front of you, keep your toes touching, your feet straight. So feet like that, put your hands on your hip crest. And now holding that pressure on your hip crest, rotate your feet out and you will feel that your pelvis opens up. So feet together, holding on that iliac crest, open up your legs and you will actually feel your pelvis opening up. That is why we tie the feet together. That gets that pelvis closer. It closes that pelvis.
Okay.
OEC6 talks about during our secondary patient assessment, we're only squeezing the pelvic once. This is not something that every patroller that subsequently comes on should squeeze the pelvis again. So if you have that positive sign, note that instability or any movement. And then the other high important thing is remember not to log roll these patients. So we'd want to use something like a bridge lift. So pelvic binders. So if we're doing a sheet, whatever method we want to use, it is really important that where we are putting it is at the greater trochanter of the hip. So that's the part of your hip joint that kind of protrudes out that bony provenance. It is not the iliac crest, that hip crest that you were feeling right now for the exercise. That's not where you put the pelvic binder. You want that pelvic binder down lower over their hip, and we're going to tie their feet together. One of the things that is interesting, OEC 6 doesn't mention this, but it's, I think, really important. You got to empty their pockets. If they have keys or a cell phone or something in their pocket, and now you're putting on a tight pelvic binder and you're getting that really taut, you can create pressure injuries or pressure wounds if they have stuff in their pockets. So if you're going to put a pelvic binder on a patient, make sure that you empty their pockets first. I thought this was cool. This is actually from the Wilderness Medicine Society. And so they create a pelvic binder using a SAM splint and a tourniquet. And so they cut a little hole in the SAM splint so that they can attach the tourniquet through it. They put the SAM splint under the patient's back and then tighten the tourniquet, and it compresses the whole system. So again, lots of different ways that you can improvise a pelvic binder, including a sheet. So you can use a sheet. Zip ties actually work really well for pelvic binders. So, and OEC 6 actually has a line in there as well that zip ties might be more ideal than a square knot. So shimmy the sheet underneath the hollow of their back. You don't want to roll these patients to get that sheet on. And then pull it tight, and you can zip tie it. So if you carry zip ties in your patrol vest, that's another good way to get these secures. This picture on the right is with a bamboo stick. You could probably use a ski pole. But if you need to get that pelvic binder tighter to get that compression, same thing like a tourniquet, you can use a windlass and then secure that windlass down. Other ideas, if you're out of everything, you can use a climbing harness. And so loosen the waist strap, slide it down lower, and then retighten that climbing harness. You can do this potentially with a jacket where you have the arms of the jacket, wrap it around and then tie that fabric and get it taut. If they have a backpack that has a hip belt, you can take the hip belt off the backpack and then use that as a pelvic binder. So again, lots of different ways that we can stabilize the pelvis. Also want to talk a little bit about extremity splinting. So OEC 6 is really big on this. It's also really big for shock because patients that are in pain and bleeding are going to be more likely to develop shock. And one of the things that splinting does, aside from providing pain relief, is that it actually prevents additional bleeding because it stabilizes the hematoma that forms within the fracture. So point tenderness is the most reliable sign and symptom of a fracture. So if someone hurts when you press, that is one of the ways that it can be reliable that they have a fracture. We do want to expose that area and ensure that it's not an open fracture, that there's significant bleeding, that we don't need to be dressing some of those wounds. When we splint, you want to make sure that you fill all those empty spaces between the limb and the splint with either some soft padding. You want to reduce that movement and the pressure point. And the whole purpose of this is that we're trying to decrease the movement on the ends of the broken bones so that that site can start to form a hematoma, have a clot, prevent less blood loss. Capillary refill, we checked before and after. Sometimes cap refill is a little bit unpredictable in a cold environment because you have that vasoconstriction. So one of the other things you can do is you can check your own cap refill and see how you're looking depending on how cold it is. You can check it on another bystander to compare. If you have a cap refill that's abnormal in a patient, it may just be because of the cold environment. And then not a lot that we can do in terms of pain control. We don't have pain medicines that we're carrying as patrollers, but OEC also talks about, put some snow into one of your gloves and put that on the fracture site. You can at least have some ice there that can help try to numb the skin and help with some of that pain. So the SAM splint is a pretty versatile splint. There's not much that a SAM splint can't do. You can improvise a cervical collar with a SAM splint. You can do an ankle stirrup, which is like that bottom right poster. You can stabilize an ankle fracture with that middle bottom one. And I wanted to talk a little bit about forearm and wrist fractures. We see a fair amount of those. For the wrist, the most comfortable position tends to be when the wrist is slightly extended and the fingers are kind of slightly curled down. That tends to be the most useful position of comfort. To illustrate the movement of the wrist and part of how splinting is actually immobilizing that entire wrist, I'm gonna have you play along with me again. So if you hold your arm out and you have your elbow bent, you will probably be able to turn your arm all the way over, right? So that motion is called supination. You can think of it like holding a bowl of soup. And so the forearm that's a whole 180 degrees that can rotate, right? So if instead now, and you have your palm down and you grasp your arm just past your elbow on your forearm there and kind of squeeze from the bottom and top, now try to rotate your wrist and get your palm up. You won't be able to. You're going to get it maybe 90 degrees is what I can get. And so what that's showing is that when we actually immobilize and secure a joint above, joint below, so we're talking about me being able to move my wrist and me securing the elbow so that I reduce some of that movement in the elbow is actually preventing a lot of the range of motion there. So when we splint someone, we're actually not only providing comfort, treating their pain, but that is why the splint is so effective at reducing the movement that can occur there. And that is what's allowing that hematoma to form so that that patient doesn't continue to have bleeding at that fracture site. So OEC also talks about the difference between tension and traction. So it's also really important that when we have a fracture, we want to get it back as close as we can to normal anatomic position. So the goal is realignment. It's not reducing that fracture or setting that fracture in the field. And there's a lot of reasons that we wouldn't use tension. If it's an open fracture, if it's severely angulated, if there's a dislocation, kids are probably not going to tolerate it, and your patient may not tolerate it because of pain. But that goal of returning to as close as you can to anatomical position when you splint is so that you prevent that movement of the broken bones and really allow that hematoma to clot and prevent that additional blood loss. Now, traction is what we are going to do when we talk about femur fractures, and that's where we're doing about 10% of their body weight. So another question here, we have a patient with a suspected mid-shaft femur fracture following a high energy trauma. Which of the following findings would prevent us from using a traction device? So 1, the patient's exhibiting signs of hemorrhagic shock. B, the patient has a suspected fracture of the pelvis or a knee injury. C, the femur fracture is open with bone ends visible. And D, the patient has laceration on the upper thigh near the fracture site. Yeah, so B, and I saw a C in there. So OEC6 now says that it's best to use a traction splint for any open or closed femur fracture that's in the middle third of the femur. Now you may have Hill policies and other things that that change that, but femur fractures, what we know about them is that you can have a significant amount of blood loss from a femur fracture. So it has been reported to be as high as 1 liter to 2.5 liters of blood. And it's because of how vascular that femur is. And you can have patients that have life-threatening bleeding from a femur fracture. So traction splints are primarily used for fractures that are in that middle third of the femur. OEC6 says for open or closed. If it's open, you want to rinse it with potable water. So that's drinking water. And if there's significant pain with traction, then you would switch to tension and rapidly transport. I think some of us have probably been caught in this in our OEC scenarios. Don't pull manual traction until you're ready to be committed to pulling that manual traction. So you don't want to get stuck there. So wait until you have things ready to go before you pull the manual traction. And again, that traction is not only helping to stabilize bleeding, but it's also providing immense pain relief to patients when they get into traction. So a lot of different varieties out there. There's the hair. This is one that goes up under the leg into the glute there. You measure it against the good leg. You want to have about 8 to 12 inches past the ankle. You're doing that upper strap, then you're doing that manual traction, and then you're securing the leg straps. There are so many wonderful videos online that depending on what your Hill uses, I would really encourage you just watch the video of how to apply the splint, the traction splint, because it's really great refresher for us if you're not doing it frequently. There's the Sager. This is the one that's going up on the inside of the leg. If you have a male patient, you want to remind them to adjust themselves. And then you rotate that splint so that the traction wheel is on the same side as the injured leg. You can tighten that up 10% of their body weight. It has the numbers on the side as you tighten it. It does apply pressure into the pelvis. So again, this is going to be one of those scenarios where if you suspect that that patient has a pelvic fracture or pelvic trauma, you don't want to be using a traction splint. And then some of the newer ones are the lateral monopole splints. So this is like the Slishman. There's a pull cord up at the top next to the hip, and that's what you pull on to tighten. These can fit pediatric patients, and they also have now a compact Slishman that goes from the knee to the femur, so it doesn't go all the way down to the ankle. And so this is one of the devices that you can use in pediatric patients. And then the other is the Kendrick traction splint. So again, it has the collapsible kind of tent poles, so you can measure it, and you can measure it down if you have a pediatric patient. That traction is pulled at the bottom of the device. There's the little strap. And so you're pulling on the strap, and that's what's producing the tension. All right, another question here. We got a patient that has a penetrating wound to the anterior chest. We identified it as a sucking chest wound, and we applied an occlusive dressing with tape on 3 sides. And now during transport, this patient's condition deteriorates. His heart rate is increasing, his blood pressure drops. What is our priority intervention? And there may be many of these may be true, but there's also one specifically that we have to be mindful of with this intervention. So A, expedite transport. B, lift a corner of the occlusive dressing. C, tape down the 4th side. And D, ventilate with a BPM. Yeah, so it's actually B. So one of the risks of an occlusive dressing is that you can create a tension pneumothorax. And so we'll talk about how that happens. So quick refresher, chest anatomy. So heart, lungs, pleura, ribs. Thoracic trauma accounts for up to 35% of trauma-related deaths in the United States, because there are a lot of critical structures here that come into play. And the morbidity and the mortality of chest trauma is also because of it has an impact on the respiratory system, it has an impact on the circulation system, or both. Rib fractures are found in 10% of trauma patients and 30% of patients presenting with chest trauma. So you do also, if you have a trauma patient that had a significant impact, you want to be thinking about that they could have rib fractures. There's a potential space between that lung and chest wall called the pleura, and that can contain a small volume of fluid. That is where we see a lot of our chest trauma problems, like pneumothorax, is occurring in that space between the chest wall and the lung. So flail chest is wild if you've seen it. I've had one case of flail chest, and it is really kind of mind-blowing when you're watching it. You get the classic paradoxical movement. So you need to have 3 consecutive ribs that are fractured in at least 2 places. And when that patient takes a breath in and their chest expands outward, that rib segment sucks in. And when they exhale, that rib segment pops out. So that's really why it's so important to look and listen and palpate when we have the trauma patients, and that we're really doing a good chest exam. And you can have respiratory compromise in these patients, not usually because of the flail segment itself, but because of the trauma that happened during the flail segment. You may have bruising on the lung and other lung issues. You do not want to wrap around the entire chest. So OEC6 talks about doing a kind of cushion splint, putting up some padding there, taping around that adjacent area, and that can just help provide some comfort for that patient with the flail segment. Pneumothorax and tension pneumothorax. So you can get in tall young men spontaneous pneumothorax. So it's one of the known kind of developmental things that happens with tall men, is that they have these little blisters on the top of their lungs. And if one of those blisters plops, they will develop a pneumothorax. And so what you will typically see in this patient is severe shortness of breath. It happens very suddenly. They have acute onset chest pain. And when you start to see tension pneumothorax, where it's actually pushing the heart and compressing the heart, is where you'll get the things like jugular vein distension. The trachea will actually start moving over. If you have a stethoscope and you listen, you won't hear breath sounds. You can also get pneumothorax from rib fractures, because when the rib fractures, it pokes into the lung. And you will also get some sense of, if you have a pneumothorax, you may feel subcutaneous emphysema. It is very weird when you feel it. It literally feels like you are pressing on Rice Krispie treats. So you will have this palpable cracking and kind of very, very odd sensation. When you have a patient that has chest trauma, is in respiratory distress, and hypotensive, you really got to be thinking about that they have a tension pneumothorax. The other thing that you can often, maybe an additional finding, is if you are bagging someone and then it is becoming very difficult to squeeze the air in, that is often also a patient that has a collapsed lung. So sucking chest wounds, that's where you have a penetrating injury into the chest. You have that open passage between the outside air and the lungs. And so when they take that breath in, air is actually getting sucked down into the chest cavity and collapsing the lung. So you may get froth or bubbles around the injury. You may get a kind of hissing sound when they take a breath in. And so the treatment for that is we're gonna seal the chest. So you can do a Ziploc bag and tape three corners of it. You can also use like petroleum gauze. And then they also commercially now make chest seal, which is an adhesive bandage. It has the vent already in it. And so all you have to do is take off the adhesive tape, slap it on over the hole, and you have a chest seal. What we had found, again, from our experience in military medicine, is that they will basically put a chest seal on any chest penetrating trauma. And that is where they were starting to see that they were having more and more people developing tension pneumothorax as a result of the chest seal. And so in the ideal state, there is still an ability for the lung to vent out through where you don't have it taped all the way down. But it's one of the things that you have to be mindful of. If you put on a chest seal on a patient and they are now starting to decompensate, OEC6 says readjust the dressing. So lift it up, vent it. You may get a bunch of air that escapes out. That's a patient that is developing a tension pneumothorax because of the chest seal. Cardiac tamponade is another thing that we'll see in trauma, where you actually are getting bleeding around the heart, and that blood is squeezing on the heart itself. And so that, again, you're going to get jugular venous distension. You're going to get that shortness of breath. If you took a blood pressure, the systolic number and diastolic number get closer and closer together. So their blood pressure may be like 100/90 or 100/95. And that's because that heart is not able to expand and contract in the same way that it could normally. So wrapping up. So the takeaways. So what do you all think are the 3 proactive steps that we can take to manage shock?
Suchin?
What are 3 things that we can do for our patients? Yep. O2, warm. That's 2 of them. What's the one other? Control bleeding. Yep. So those are the 3 things. So we don't want to miss them. When we have a patient that's in shock, we want to make sure that we really have addressed all of those. And if we have a patient that doesn't have any signs of external bleeding, we need to be focusing our assessment on if they have signs of internal bleeding. We need to really be cognizant of all of the things that can be part of that shock picture. So another one, so pelvic binders should be placed at what anatomic level? Up at the iliac crest, or are we doing it at the greater trochanter, the hip joint?
Hip joint.
Hip
Yep.
joint.
Exactly. So what I would say one of the big takeaways is I would be wary of the tachycardic patient. Whenever I have patients that are tachycardic, that's something that really makes me get out my magnifying glass and try to start figure out what do I need to investigate? Why is this patient tachycardic right now? I think we can all be proactive with addressing shock, especially keeping patients warm when we're in these cold environments. And then remember that splinting is a really powerful piece of keeping that patient stable. We're preventing more blood loss, we're reducing pain, and all of those have an impact on our ability to keep this patient alive and well. And then something to think about is, what do you have in your patrol vest that you could use to create 3 different tourniquets? What are 3 different ways that you might be able to configure the stuff that you already have in there? Upcoming chats, we're going to do one in February on airway and respiratory emergencies, one on 3/16 on cardiovascular and neurologic. And then please give feedback to me on these lectures. This is a QR code. Hopefully it will keep working this time, but if you give us some feedback, it is anonymous. I will not know who you are. You are welcome to say whatever you would like that you think would be valuable for me to hear, and give us some ideas of some future sessions. I am going to turn off the presentation, and I know we have a couple things to